Dr. LJ Punch is currently the executive and medical director of Power for STL, which is a community of individuals who are working to reduce the impact of trauma in the St. Louis region. So thank you so much for speaking to us today.
I appreciate you accommodating my presenting virtually. I had really hoped to be with you all in person today, but I have another conference and a very busy clinic here in St. Louis, and it just was not possible for me to get away. But I'm really excited to spend a little time with you all today. So again, I'm Dr. LJ Punch. I describe myself as a trauma surgeon in recovery. My pronouns are he and they, and I'm going to be sharing a little bit about involving community. So disclosure, I'll make sure this isn't getting in your way. Okay. I work, speak, and live in the Black American experience. And so my perspective and what I share is completely structured around that experience. And it has been so important in my career and in my work to unapologetically center that experience for the purpose of both honoring and learning from the experience so that I can both serve Black people, but also so that the wisdom and the healing power that comes from the Black American experience is available to all. I want to begin with a story. It's a story of Freedom House. Freedom House, if you don't know about it, you can learn more about just by scanning this code, was a movement and organization in Pittsburgh, which was in part founded and structured by Dr. Peter Safford, who is well known for his work in CPR, closed chest resuscitation, and critical care. But he also helped found this organization, which was structured to improve pre-hospital care for disenfranchised and divested Black communities in Pittsburgh before modern EMS systems were in place. And the system of care, which you may have heard about before, trained Black men, specifically previously incarcerated Black men, in advanced techniques in pre-hospital care that created a cohort of well-equipped mobile outreach and engagement using something far better than a police paddy wagon or a hearse to move people as a publicly available resource. The Freedom House was run as a pilot program with civic funding that over the course of a very short period of time provided incredibly advanced and improved outcomes in pre-hospital care when compared to traditional first response by, for instance, law enforcement. People got better care, but so much of this model has, I think, been lost in translation. The model was so successful, it was adapted by Pittsburgh. Freedom House was disfunded and disbanded, and currently modern pre-hospital EMS care owes a great deal of its structure to that initial project. But what was left behind and what was left out of the model that this article that I've linked here goes over was the way in which who did the care in Freedom House's model and where they were from impacted their capacity to give effective pre-hospital trauma care. When we think about involving community, I think it's important that we not use actually the term stakeholder, because first of all, stakeholder is a term of oppression. It has to do with the seizure of indigenous lands. But community isn't actually just a kind of passive partner. It is actually where healing comes from. And similar to the model of Freedom House, and so much that we have to sort of, so much we owe to that model in creating current structures of care, you cannot separate where and who the care comes from when we think about community. Community is not simply someone we should have at the table. It's not simply an organization we should do a focus group with. It is where and from whom healing comes from. We want to separate ourselves from the thought that community is not the point. In fact, everything we do in our work around trauma healing and recovery and the hope to advance equity must center community. In fact, separation from community is antagonistic to the ways that we need to heal from trauma. And that gap that occurs between bringing people into areas of care, systems of care, hospital systems, trauma centers, and those that are coming from the community is not just an issue when it comes to understand who we're serving, but it's an issue when we think about the chasm that exists between those who provide care now and those who are receiving the care. Far from the model of Freedom House, current trauma systems, academic trauma centers, and settings where people get emergency services are frequently staffed, led, and supported by people whose lived experience, class, education, and privilege is far different from the ones that are being served. And that chasm creates a false dichotomy between the idea of community and the inner circle of those who are doing the healing work. So the challenge in engaging the community that I've already said is a super important part of what it is to provide trauma healing care is that the institutions in which that care is provided represent such profound harm to those same bodies of people. I mean, let's talk about it. When we're talking about community, we're not talking about the folks who are very, very okay with the idea of engaging in institution-based healthcare and emergency departments. I'm talking about anybody whose lived experience, whose racial, social identity, and in any way separates them from the institution in which they must be seeking care represents. In other words, any institution can represent harm to anybody when there's a dichotomy, when there's a tension, when there's a separation from the community where they live and work and love. Is different from the community that's working inside the institution. But it's not just that there's a difference, that the institution represents harm, but institutions can produce harm. And that can make it so that communities are very unwilling to engage with those same institutions. The true injury that I practice inside around the issue of trauma is that people are suffering from broken trust, and the institutions themselves of trauma care can perpetuate that broken trust. This picture gets across that feeling completely for me. This is a picture of someone in the midst of 3 pandemics: the pandemic of COVID, the pandemic of racism, and the pandemic of what bullets are doing in our bodies, in our communities, in our lives. And while this person is trying to cover their face to protect themselves, they are also having to wash their face from the impact of confronting racism. Those trade-offs, that tension, can make it exceptionally difficult for any trauma system, any trauma program, any trauma care to be engaged. I want to take us through all this importance and the who and the where that care is coming from, and community is the source of care. At the same time, there's this stress and this pressure that institutions are not trustworthy. How can we objectively, structurally address that chasm. The CDC describes a continuum of community engagement, which is well described and well known, that involved a progressive development of relationship and collaboration that must be expressed consistently over time to, guess what, heal that broken trust. It goes from outreach, in which there's superficial engagement. This is sort of the, jeans and a t-shirt and doing a community garden. I'm not saying community gardens aren't important, but that ain't it. That is just the beginning. It's sort of like the first date. And then consultation, when you're starting to talk and exchange information, involvement now, when the relationship is deepening and there's communication flowing in both ways, and there is consequence of that communication. Flowing then into collaboration, where it's not just the communication going both ways, but the power is beginning to balance itself toward the total expression of community engagement, which is shared leadership. I am the founder and executive director of an organization that has given rise to a clinic called the Bullet Related Injury Clinic. It's a clinic in St. Louis that gives aftercare for patients and their families who have been shot, who are discharged from the emergency department. The institutions of care in St. Louis for this community represented harm, and I was part of that community. I tried to go through the continuum of community engagement on my own for a couple of years, better understanding and trying to involve myself in community and helping understand the needs and the ways that the trauma center could better serve the community. And I found in that process over and over and over again, the broken trust and the active harm made it impossible to create the kinds of collaboration that I hoped for. So when the idea came to build a clinic for aftercare for bullet injuries, an injury that was a leading cause of concern and death in the St. Louis region, I took the lessons of community engagement and carried out a years-long process. And I want to share a little bit about how I did that. First of all, the community engagement began by evaluating the internal reality that the community was experiencing. The process of restorative justice requires us to first be very clear as systems and providers on what we're doing and how we're doing it. I found that our trauma registry demonstrated that 50% of folks who were shot and evaluated in the largest trauma center in Missouri were then sent home, a statistic that is true state across the country. This is not just St. Louis, but 65% of those folks in the era of not expanding Medicaid did not have insurance. And many of them were young Black men. But beyond being discharged, there were numerous gaps in care, from the way that people were triaged in the initial assessment in the emergency room, to the way they had access to aftercare in the clinic, regardless of their payer status. And what I saw in evaluating that data and looking at that experience was moment after moment after moment after moment of increasing harm and broken trust. I started to realize that listening to the community and looking at this experience, the number one thing that I needed to do in building a new opportunity for wellness was to first attend to that broken trust. Involving community is not a passive thing. It's sort of be like going on a date with somebody, but never asking them their name and never asking them their favorite color and never caring where they're born, where they're from, and what they care about. We must get to a point where we don't just identify the community voice, but we look at how we are actively interacting with that voice. After this gap in care, it was understood, 2 project managers from a regional health equity organization in St. Louis assisted with the convening of individuals and groups to look at those unmet needs and how they were not just manifesting inside the healthcare system, but the way they were manifesting within the community and themselves. We scheduled every other week meetings and met and went through every single component of building out this community resource. And then the launch for the clinic was to occur in early 2020. There were a couple other things going on in early 2020, but we were going to launch, and there were multiple concerns from this same group that the process would not be trauma informed, and that though a resource would be created, it would not be reflective of a resource the community could consistently use. And guess what? We stopped. Because involving community is not simply listening, not simply getting some feedback, but it's responding and collaborating that feedback, even when it's really, really inconvenient and hard to do so. The BRIC was delayed another 9 months before its launch to restructure to assure that those trauma-inducing parts of the experience were eliminated. That process of community engagement led to the BRIC pilot, which demonstrated a profound amount of unmet clinical need and addressed ineffective clinical care for the issue of bullet-related injuries. So what does it mean to involve the community? First, we have to start by stopping lying to people. There are many things that we talk about as if they are fact to our individual patients and to our communities at large that we actually don't know. We need to start listening to people and understanding what matters to them most in their health and well-being. We need to make a longitudinal commitment to their care and what it means for them to interact with systems of care. And then we need to work in loving partnership with those already doing the work, even when we have to make really challenging choices to continue that partnership, just like we do in our relationships in our own lives. Involving community begins with making a commitment to be in trauma-informed collaborative relationship. I appreciate your time and your willingness to hear my thoughts on this very important topic, and have more information about the Bullet-Related Injury Clinic available here. Also happy to share with the panel. Thanks so much.